मुझे कैसे पता कि कौन आ रहा है?
बाद में आएगा,
बाद में आएगा।
अभी
मेरा ही डीएम है वैसे। शुरू कर दूँ?
शुरू कर दो, स्टार्ट।
Hello. Okay, so good afternoon and boys and girls. So here we are, and I just thought you can't see me, but you can hear me, and this is one of the experimental initiatives we thought we would take in view of the fact that we're not having ongoing academics. This is more virtual, but I thought this is something which you would be interested in, because all of you are well versed with thrombolysing and acute ischemic stroke, but beyond the guidelines and beyond what's written in textbooks, sometimes you have to search for the proof to do a particular thing in a particular way. So I thought I'll just talk to you about it, and I must acknowledge the help of my colleague and friend Dr. Rohit Bhatia, who has given me these slides. And so let's, this is a kind of a story, so let's I wish I could see you all, so that I could see a hand up and I could ask, and then we could have that kind of interaction. But I believe in this facility, once we go through all this presentation, then you could ask questions and I can see the questions being typed, and then I could answer back either verbally or I could even type back. Okay, and you can always catch me whenever you can. Alright, so let's get going. So you have all these guidelines, right? You have the international guidelines, and we also have our own guidelines which have also been recently updated, and these give you a direction, and these give you a certain amount of confidence to deal with in a particular clinical situation. But then there would always be gray zones. Remember that patients never read textbooks and come to you, so there would be a bunch of factors which would then make these guidelines a little gray at times. So let's see what they could be, right? So although we have both these agents, and both of them are being used extensively, we probably have a lot of evidence with the second lytic agent as well. But current discussion is with the tissue plasminogen activator, and we all know that these are the known indications, and we do have that the time window for which this can be given is increasing by by few months every time, and now we actually have evidence to say that even up to 9 hours with evidence of a mismatch, you're able to give, these are not wake up strokes, I mean these are known, and even up to 9 hours, having known when the stroke has started, probably you can still have that window of patients who you can give intravenous thrombolysis. So this is growing field. Probably the guidelines will again change after a while, but at the current point of time, when you're sticking to the guidelines, it is within 4.5 hours, and obviously the big fat contraindication is a bleed. So let's start with the first case. So you have an elderly gentleman, 85. So the classic history of acute onset deficit, and is in the triage within 1 hour. You have a big NIHSS. You don't have a very great aspects. Blood pressure, sugar is fine, and the ECG shows that he has an atrial fibrillation. So this is one of those elderly patients with atrial fibrillation, a very common scenario, who's coming to you in time. So will you thrombolyze? You will thrombolyze. So we'll come to that, the evidence as it exists. Now he has a right hemiparesis. So therefore, can you let me know the what are the areas which are possibly involved here? Ischemia. Now this is the caudate, this is the putamen, and you have the internal capsule, and you have the insula. So what is happening here? You certainly don't, you have a putamen which is involved, right? You have an insula which is involved, and possibly a part of internal capsule. And if you go into another cut which you don't have here, so maybe some of those other M areas are also involved. So this person, the case history says aspects of 7, which is just about a borderline saying a good or bad, and you have an angio which clearly shows you that there is a large artery which is involved. So he went ahead, there was an IV, and then it was followed by a thrombectomy, and subsequent to that there has been okay. So here the purpose of discussion here is that the age. Now, does age remain a factor for any inclusion or exclusion into a particular thing? At least for acute ischemic stroke, no longer. So this was there, you know, all of you know that the guidelines which came in following the NINS protocol were all more of safety based, and the experts have thought that in their best wisdom that these are possible exclusions, keeping in view that these may be the situations where the safety may be compromised. Therefore, those guidelines have come in, and certainly age has always been a bugbear. And if you really look at the outcomes of a particular disease, not just a stroke, age is a bugbear. You do know that age per se is not a great, factor when you're looking at extremes of age. A very young and a very old person, the outcomes are not necessarily as good as they turn out to be in a young, robust individual. So the robustness is also an important thing along with age. Therefore, the evidence to say that in an elderly person, if you treat with thrombolysis, there is likely to be more bleed has not been borne out with increasing evidence, and the fact that they would necessarily do badly is also not borne out. So therefore, age does not stay as a contraindication, which is true for both 3 hours and also 3 to 4.5 hours. And this is the the summary of all the guidelines that we have currently, the evidence that we have currently. Age is no longer a contraindication. Yes, sometimes when you have an age along with a premorbid MRS of the situation wherein you have an advanced Alzheimer's, there is always an MRS of already 4 or 5, and you have a fresh stroke happening there, then you have to weigh the risk versus benefits and several other factors. But age per se would not be a contraindication. Then what about the number case 2? So that was easy case, and we are all doing it. And as I mean, this is a personal communication. The oldest patient who's been thrombolyzed in India, I believe, is a 97-year-old. So that as far has been the limits to where the thrombolysis has been done. So although we really don't have evidence of saying that what about novogenarians, so but then above 80 years has not had actually a limit to what age we can thrombolyze. So currently we are thrombolizing. The case number 2 is a 61-year-old lady. She is hypertensive. She is stage 3 CKD. 2 years ago she's had a stroke. She is on a single antiplatelet, and now she's got a left hemiparesis. She's come within 3.5 hours to the triage area, and she has a low NIHSS, good aspects, and no large vessel occlusion. So she's been given the TPA, and the NIHSS had dropped down from NIHSS 4 to 2. Remember this case, everything which is marked in green are the issues we will be talking about: renal disease, single antiplatelet, low NIHSS, and having had a stroke some time back. Okay, and in this patient, she's had an old stroke. The fresh stroke doesn't show evidence, and there is no large vessel, and she's done well. All right, there's not been any fresh problems which is seen on the CT scan. Similarly, the case number 3 is an elderly lady, again an old stroke 3 years ago, and this time on double antiplatelets, all right, which is again a very common scenario, and now presents with a reasonably moderate bad stroke. In a sense, the NIHS is 13. She's come to the triage within 2 hours, and she's got a significant neurological deficit. So in this case, after NIHSS, after the TPA, the NIHSS has improved, and there has been now, this is the ischemic zone. What is this area? Predominantly by ACA, and she did well. Now, what are the issues here? What do we do when you have a history of a previous stroke? What do you do when you have a minor stroke as determined by a low NIHSS, which is not necessarily sine qua non to non-disabling stroke? The previous antiplatelet used both single antiplatelets and dual antiplatelets, and the presence, and when you know the patient is a known case of CKD. So previous ischemic stroke, what does the evidence say? Within 3 months of a previous stroke, the original guidelines said the TPA may be harmful. Okay. That said, subsequent to which all the revised guidelines have taken it out, because a lot depends upon the time which has elapsed since the previous stroke. The second is the volume of parenchymal injury, the severity and location of the prior stroke. Now things become even more grey when you're talking of a bleed prior, but here we are talking about a previous ischemic event. So when you have an ischemic event which had happened 2 months ago, maybe a moderate risk, 3 months ago a very low risk, I would take really no risk. And if you really have a huge volume which has been implicated, say 2 weeks ago there was a major stroke, one hemisphere is all gone, and now there's a cardioembolic event and he's had another stroke, and we've had such cases. There you look at the risk benefit ratio. You probably need to have a dialogue with the family. You need to see, do I really treat this patient? Will I be, maybe there'll be more bleed happening in this patient because the ischemic zone is still very much there as a fresh zone of parenchymal injury. So the volume, the freshness will be an issue, but by and large, if there is a previous stroke, say 2 months ago, and it is a moderate side stroke, it is now a chronic infarct, and because the stroke prophylaxis was not adequate and has not been subtyped, has not been compliant for zillion reasons, and another stroke, there's no reason why you should not thrombolyze. So just capture this slide, and this will at least give you the evidence to move ahead. There would still be grey zones, but largely at least that blanket statement that if you've had a previous stroke in the last 3 months, don't thrombolyze, doesn't hold true anymore. And what about the previous antiplatelet agent use and the outcomes after IVT? We've had meta-analysis, and this has been published in the year 2015 of nearly 20,000 patients. About 1/3 had a pre-thrombolysis antiplatelet use. And what are the outcomes that you want to look at? You want to look at what's been the primary outcome. That's the outcome is essentially how much have they improved. The other is, the biggest bugbear being how much would they bleed. So the risk of symptomatic intracranial bleed, you see, not just any bleed but a symptomatic bleed, would definitely be more when you use an antiplatelet. So any antiplatelet use, you have the figures up there. Aspirin monotherapy being the commonest. The other is, of course, when you have duet. And even in duet, the most common duet is aspirin clopidogrel versus aspirin diprodamol. And you have those figures up there, right? So yes, they probably will bleed more. But then, when the outcomes of IVT in acute ischemic stroke patients in prior duet were analyzed, and this is a post, there's a lot of good data which comes out of this SITS registries. This is safe implementation of thrombolysis and safe implementation of treatments in stroke per se. So initially it was for thrombolysis, and later on they've included all forms of, treatment for stroke, including the mechanical thrombectomy and, treatment of blood pressure and what have you. These are ongoing registries, initially only for Europe, then they went on to Asia, then they went into Southeast Asia, then Africa, and almost the whole world. And now with that immense amount of information that has been gathered, it seems that their 3-month mortality rates and functional outcomes were compared to pre-stroke antiplatelet naive patients, and they found that they were all pretty similar. So which means that if somebody has taken a duet last night and the next morning has a stroke, you don't need to withhold your IVT if all other criteria fall into place. Okay, so because the The antiplatelet use is so much more, so common, isn't it? You don't stop antiplatelet. That is true. Now, there's a little corollary to it because we are in a dialogue. Let me tell you also about this, that person who's on antiplatelet use and stops it for some reason, and most commonly it is because of an impending surgery. So a lot of times people stop antiplatelets, and it is seen that it is that 1 week is the really risk prone state for occurrence or of a stroke recurrence. And this is true. This is for both anticoagulants, and time and again. In fact, now the last admission that we've had in NS5 is the same thing. Anticoagulant being stopped for valve surgery, and she comes back with a massive cardioembolic event. Which is this is true for antiplatelets as well as anticoagulants. Now, anticoagulants is a no-brainer, you can understand, but antiplatelets also, for some reason, although for an aspirin we know that you stop today, things are not going to come back to baseline the next day, still it seems over the next 1 week the stroke recurrence rate is pretty high. And this has been seen in major abdominal surgery even prior to, say, a lot of these joint replacements. So nearly half of all the patients with acute ischemic stroke are on antiplatelets prior to thrombolysis. And you know that being on aspirin is not going to give them a 100% shield of cover from occurrence of a stroke. So this concern of a symptomatic bleed while the patient is on antiplatelet is genuine. But the recommendations as it stands, whether it is a single antiplatelet or a duet, thrombolysis is recommended. Okay, that's the take home message. Now what about CKD? And what about end-stage renal disease? That's the worst, isn't it? Now, ESRD on hemodialysis and normal APTT. Okay, so the normal APTT, that means the heparin usage as such has not led to a state where it can produce a bleed. IV alteplase is recommended. When you have an elevated APTT, say more than 45 seconds, then there is an elevated risk for hemorrhagic complications. So in ESRD, where you have an abnormal platelet function, impaired clot retraction, altered endothelium, reductions in inhibitors of blood coagulation, that is antithrombin 3 and protein C, they have all been documented in people with ESRD. So as such, it is a situation wherein there is a bleeding complication. There is a coagulation abnormality. And in such patients, APTT can be taken as a useful bedside marker which you can obtain pretty much easily and instantly. And going by APTT, you can decide whether you need to give thrombolysis or not. Said that again, renal failure is an independent predictor of poor outcome in acute stroke. We do have one of our residents who's actually done work on the outcome of a stroke when a person develops the renal impairment after admission. So it is this evidence is also growing that even if a person does not have a priori renal failure or a renal impairment, when they do develop a renal impairment for reasons more than one, their outcome in that event of an acute stroke is not great. So renal impairment is turning out to be one of the important parameters to predict an outcome after acute stroke. What about minor strokes? Now this is my favorite topic. To me, a stroke is a stroke is a stroke. Okay, there's nothing really like a minor or major. That's an outcome measure. Minor stroke to me is something which is a God-given opportunity to prevent something major from happening, and also to you need to realize that a deficit is a deficit. So a minor stroke has definitions in terms of the number which you allocate in an NIHSS, and you also know that NIHSS number is not sine qua non to the amount of a functional disability, and this we know that you can have a NIHSS score low and you have a disabling deficit. So what are the disabling deficits? You know it, you have language dysfunction, so all forms of aphasia. When your speech is impaired in terms of both language as well as articulation, to be both in fact are important. The second is your hemi-neglect. The third is your hemianopia. So when you have these disabling deficits, you can just have an ataxia. Sometimes that's disabling. So anything which is NIHSS score which is just 4, less than 5, 2 and 3, but is disabling, to me is no longer a minor stroke. Said that, you can present with a minor stroke, and when you automatically do your vessel imaging, you also know that it is just a harbinger of something major happening subsequently. So you know that you can have a large vessel occlusion presenting as minor strokes, even presenting as lacunes in minor strokes. So in such a situation, in your triage, when you do vessel imaging and you've seen it's a large vessel, well, go ahead. Now that's a God-given opportunity, a window to be able to correct and, preempt the probability of a major event from happening. Therefore, what has happened subsequently is that the guideline came in that, look, when a minor stroke happens and the patient has come to you, the triage in time, don't shoo him off. Don't say something got minor, go home. Please manage him. Said that, there are also situations when an event is truly minor. It is non-disabling. And you do have this theoretical but definitive risk of, however small, a bleed with a thrombolytic agent. So somewhere you need to have a fine balance. And then came PRISM's randomized clinical trial, so done by Pooja et al. So they did this double-blind, placebo-controlled, multi-center RCT in the US, with Cincinnati being the hub. And 303 patients of minor events randomized to alteplase versus none, and in them they didn't find a huge difference in the functional outcome between those who got treated versus those who did not, with a definitive, at least statistically different, indications that there is more bleed in the alteplase group. This again a no-brainer, but then the ultimate guidelines stay as they exist on the current slide. So for otherwise eligible patients, remember, they have to fit in all other criteria in terms of time, in terms of your imaging, in terms of everything else. That mild but disabling stroke symptoms, you do recommend IV alteplase, whether it is within 3 hours, and 3 to 4.5 hours, you have a level a little smaller, but yes, go ahead. But there is no benefit in mild with a non-disabling stroke symptoms. I reiterate here that a non-disabling stroke symptom and mild who also do not have a vessel occlusion of a large vessel occlusion of another subtype, okay, which is actually giving you a window of opportunity. Therein, you need to emergently manage the subtype as well, otherwise you will be having another stroke very soon. Remember the stroke prone state? The stroke prone state as it exists is in the first 3 weeks, and it largely depends upon what is the stroke subtype as well. So it is absolutely paramount importance that you should have a stroke subtype before you even contemplate discharge of a patient. Let's look at a case 4. So this is a 58 years old gentleman. He's a known hypertensive since many years. Had a bleed, okay. This is an intracerebral hemorrhage, small volume, ganglionic, 3 years ago, recovered well, and then now has come with a left-sided ataxic paresis in hospital within 3 hours, and NIHSS is 9. CT doesn't show any fresh bleed. The old one is just a little cavity. It's not a large vessel. Aspects 9, BP well controlled. What do? There's a bleed in the past. Now the original NINS guideline said any bleed in the history of his existence, don't thrombolyze. Will you do that? So let's see. So should we exclude acute stroke patients with previous intracerebral hemorrhage from receiving IVT? So a multi-center nationwide stroke registry database in Korea, and they looked at the primary outcome. What is the outcome? Well, what are you scared of? Development of another bleed. So that's what they did. And they also looked at the functional outcome, and they scored those functional outcomes into excellent, good, and the ordinary, and then mortality, discharge in 3 months. So what did they find? They found that the development of bleed was not too hugely different between the groups who had a bleed earlier versus those who didn't have a bleed earlier. Alright, so the previous ICH did not significantly increase the risk of SICH, mortality, and the most of the functional outcome measures, which meant that you need to give the thrombolysis. So therefore, when you have previous ICH, there are several other parameters you need to consider. So thrombolysis is potentially harmful, alright, but said that, the risk of thrombolysis in prior ICH varies based upon the time elapsed. So if you have an ICH within the last 1 year versus more than a year, the etiology of the previous ICH, it could be a subarachnoid bleed with an aneurysm. Have you clipped? Have you coiled the aneurysm? Or was it an AV malformation? Was it a lobar bleed? Because, is it because of an amyloid angiopathy? Is it a lobar location bleed? The surgical evacuation of hematoma. What is the volume of residual encephalomalacia? What about the microbleeds? Cerebral microbleeds are not a contraindication, but the number of cerebral microbleeds will really throw up a red flag. So the basal type hypertensive CMBs versus the cortico-subcortical type, which is a red flag, again amyloid angiopathy. High cerebral microbleeds, that is a burden more than 10, is definitely a high risk of SICH, not just for thrombolysis, even when you give them antiplatelets, they bleed. So therefore, these are the situations where there is uncertain benefit of TPA. But supposing you don't have these kind of problems, that is, if you have a bleed, a minor bleed, a tiny slit 2 years back, and that has been a hypertensive bleed, then there's no reason why you can't thrombolyze. Okay? But please do look out for all the other reasons why he had a bleed earlier. It was not a hypertensive bleed. It was an amyloid angiopathy. You had an aneurysm which was clipped very recently, or you have a huge lobar bleed sitting there, say 3 months earlier, which has resolved, but it has a big cavity sitting there. Now these are red flags. But the common garden variety of previous ICH, in such situations you can thrombolyze. More pertinent in this probably is also, though that is not the subject of today's topic, is also giving them antiplatelets for stroke prophylaxis. And now that a previous ICH need not necessarily be a blanket contraindication to put them on stroke prophylaxis. You need to see essentially when was the last bleed, and and you also know that stroke begets stroke, and a lot of these bleeds actually have silent ischemia, a whole lot of white matter changes, and the last of it all is that heart and brain, it doesn't obviate them from having a heart attack or even having a stent put in because of a blocked coronary. So these are the situations for a stroke prophylaxis which draws up broader guidelines, and someday we'll talk about stroke prophylaxis. In that time we will also discuss about antiplatelets when you had a previous bleed. Case 5, 60 years, male patient, onset right hemiplegia, aphasia 4 hours, big fat MCA sitting there, right? So what do you do here? What is happening here? Tell me. These are early ischemic changes, isn't it? Will you thrombolyze here? Well, there's been a lot of literature even on this as to when you have early ischemic changes in this kind. In fact, this is actually well beyond the early ischemic changes. There's been studies which looked into the volume of an early ischemic change and what has been the outcome per se. But I would look at this as a red flag, and please go ahead with a mismatch before you go ahead and give IVT. But in a lot of these situations, you probably can still take it out mechanically. If this kind of ischemic change wasn't there, then of course there's nothing which prevents you from a bridge IVT and MT. But in these kind of situations, probably you still need to look at a mismatch. Here's a 64-year-old gentleman, known atrial fibrillation for last 4 years and has been on anticoagulant. The last INR 1 month ago was 2.1. Remember? 1 month ago. Now comes with an acute weakness in hospital, in triage within 2.5 hours, big NIHSS, no bleed aspects, just about, well, on the borderline. Urgent INR is undercorrected. So what do you do in this situation? Undercorrected INR there. Fortunately, you could have a point of care system. You could do the INR is 1.4. So what are the guidelines? Parenteral anticoagulation versus VKA. When somebody is being given low molecular weight heparin and there is a full therapeutic dose received within the last 24 hours preceding the stroke onset, like it happens in a lot of our cardiac patients and CCUs or on-table patients, don't thrombolyze. Okay, this is for IVT. You can certainly do mechanical. Here you do have a class 3 evidence of doing harm. But when you're giving prophylactic dose of low molecular heparin, especially when you have had a heparin, say 12 hours earlier, one dose, you can thrombolyze. And when person is on heparin, do an APTT. If it is more than 40 seconds, don't thrombolyze. Less than 40 seconds, thrombolyze. When a patient is on VKA, INR more than 1.7 or a prothrombin time of more than 15 seconds, don't thrombolyze. When the INR is less than 1.7, it's reasonable to thrombolyze. Now what about the newer anticoagulants? We have large amount of data now on the usage of the newer anticoagulants now, and people have looked into this and looked at the safety of IVT while the patient is on the newer anticoagulants. Lots of data. The newer anticoagulants versus those not anticoagulated, newer anticoagulants and VKA, various studies. Let's come down to the guidelines. So the current usage of dabigatran, which is a direct thrombin inhibitor, or factor Xa inhibitors, which are apixaban, rivaroxaban or edoxaban. So you will thrombolyze if the last dose is more than 48 hours ago. So that makes it life very simple. You know definitely that it has been 48 hours since the last dose was taken. Go ahead and thrombolyze. Problem arises when one does not know or it is in the last 48 hours. Then when you have an APTT and INR, equivalent clotting time and factor Xa SA, these are normal, and then you thrombolyze. Or you're looking at the plasma apixaban, edoxaban, rivaroxaban level, or dabigatran antidote you've given, edoxizumab, then you do it. And of course the latest kid on the block, andexarat alpha, if available. Now to me, in my practical world, even edoxizumab is probably not practical, although you have lot of reports coming up across Indian subcontinent about this, but I guess in our clinical practice setting that is difficult, and we certainly don't have these other levels, right? We don't have ACT and factor Xa, so what do we do? So roughly, although this is not a guideline, but this is in vogue in practice, I must put a red flag to this. But when you're driven up against the wall, like now we are with corona, the outbreak all over, you do try to find solutions when you're driven up against the wall and you don't have this specific infrastructure with you. So roughly, boys and girls, when you're looking at dabigatran, do APTT, and we're looking at all the bands, that is apixaban or rivaroxaban. Edoxaban is not with us. You look at PT-INR. So if you have point of care PT-INR and INR is normal, most likely, I'm not saying it is sine qua non, but most likely you're safe to go ahead and thrombolyze here. And when you're looking at dabigatran and APTT is okay, most likely you're okay to give thrombolyze when a person has been on dabigatran. Roughly, this is in a practical, say, developing world when we are not having this infrastructure. But when you do have it, these are the guidelines that are available to you. So what about the safety and efficacy in current systemic malignancy? Not well established, probably depends upon the malignancy itself. But it is said that when the systemic malignancy is there, but there's a reasonable, that is more than 6 months life expectancy is possible, will benefit from IV alteplase if no other contraindication, that is, there's no bleeding diathesis, there's no recent bleeding, there's no recent surgery and so on. What about intraaxial, intracranial neoplasm? IV alteplase treatment potentially harmful. Okay, so when you're looking at a brain stem neoplasm, well, that's a peculiar situation, even if it is extraaxial neoplasm. So that again, they're all gray zone. So if you have a incidental meningioma which is sitting, Fox meningioma sitting somewhere, which has been there for the last 10 years, will you not give thrombolysis? Well, that's gray again, individualized, and you can take a definitive call on that. But if you have a grade 3 neoplasm sitting there, there's already a bleed in the neoplasm, or you have a brainstem neoplasm, then probably no. Okay. Acute MI or history of recent MI, I think this is really pertinent, because this is something which we deal day in and day out. So for patients, these have all been contraindications earlier. Now for patients presenting with concurrent ischemic stroke and acute MI, treatment with intravenous TPA at the dose appropriate for cerebral ischemia, followed by the PTCA and stenting if indicated, is reasonable. So please stick to this. Also, for patients presenting with ischemic stroke and history of recent MI in the past 3 months, treating ischemic stroke with IV TPA is reasonable if the recent MI was non-STEMI. The recent MI was STEMI involving right or inferior myocardium, and may be reasonable if recent MI was STEMI involving the left anterior myocardium. Why did they say this? Because of the original problem that this may cause pericarditis. There is a pericarditis following acute MI, and you give this thrombolytic agent, there could be a pericardial hemorrhage, and there could be a tamponade, and so on and so forth. But let me flag another problem. We've also had cases wherein, there was an acute ischemic event, patient was thrombolized, and remember, echo is not mandatory. Echo doesn't fall into the checklist before thrombolizing. So this person was being wheeled in to the stroke unit, and while being wheeled in, thrombolized, did an echo, and was being wheeled in. And the echo showed a left ventricular thrombus. Okay. So then he was wheeled into stroke unit, and they were wondering what is to be done. He was just being thrombolized with intravenous thrombolysis. He's fully awake, he's conscious, his NIHS has dropped down, he's improved. Do we give heparin, not give heparin? And lo and behold, he had a massive stroke. And this time it was an embolic event which actually went into the basilar artery, and his brainstem got completely involved with an MRS of 5. Survival with an MRS of 5. So what happened here? How could you prevent this from happening? Really, when you retrace the steps and you go back into the clinical stroke care pathway, you just went in along with the guidelines, but it was unfortunate. Was it possible that this person, did he require echo? Well, nobody knew. There was no history. And out of the blue, this was sitting there. He's not a known cardiac patient. So these things may happen. With the same kind of risk factors, there could be silent, coronary issues happening. And the heart and brain are intricately related in ways more than one. But these are the guidelines, remember, and always red flag when something like this is there. When you're having an arrhythmic discharge, because that's the reason a continuous ECG monitoring is required. The cardiac monitoring becomes very important whenever you're managing a stroke patient, and that's part of your stroke unit care. Remember, a stroke unit management is far more important in bettering your stroke outcome. You just can't just thrombolize or reperfuse and vanish from the scene, and that would really lead you nowhere. So come on the last few cases now. 72 years lady admitted, operated for a total hip replacement, day 14, doing reasonably well. Mild weakness of right side, now severe dysarthria, sudden onset, NIHS of 6. CT, no bleed, no occlusion, aspects of 9. Go ahead and thrombolize. Why? Well, there are major and minor surgeries. So major surgeries are opening up of major body cavities like abdomen, chest, skull. Surgery in well vascularized tissue like chronic mucosa or prostate or any of the large arteries. Vital organs can be stressed under GA, at least 1 day stay after major surgery. Okay. Now minor surgeries are major body cavities are not open, no affection of well vascularized tissue, large arteries, vital organs not stressed, local, regional, discharge same day usually. So that's usually the way you define a major and minor surgeries. So what do? Intracranial spinal surgery in past 3 months, don't thrombolize. Okay. Recent major surgery like CABG, obstetric delivery, organ biopsy within the last 2 weeks, you probably can give TPA. And remember, it's not just IVT, reperfusion is not contraindicated. Therefore, if you can't give IVT, you can always do a mechanical if it's a large vessel occlusion. Risk of surgical site of bleed versus benefit of stroke treatment is to be individualized and decided with each patient. In the last patient, I would go ahead. Infective endocarditis, don't thrombolyze. I don't think that it's a no-brainer. All of us know about it, right? Pregnancy, postpartum, well, boys and girls, we've been doing this, isn't it? We thrombolized at 28 years old with twin pregnancy. In fact, we transferred that patient from gynae ward to our ward and thrombolized her. So remember, you're actually, in that case, we'd saved 3 lives, certainly. So a lot of them are cardiac. They would be on anticoagulation. There would be some issues and they would get a stroke. So alteplase doesn't cross placenta. It's the only thing is you have to, it's a team management. You have to have an obstetrician gynecologist on board. You must have a perinatologist on board if, you know, immediately the person is, the mother is going to deliver. So, but remember, these are not now contraindications. There's been extensive evidence coming up, although they're not being recorded and published, but, you know, a lot of us are doing this. 55-year-old squamous cell carcinoma, lung, hypertension, smoker, BD, and now comes with a stroke, 4 hours, aspect 7, CT and no LVO, TPA given, NHS 2, MRS 1 at discharge, right? So, clearly, such patients you can thrombolyze. You see, what does this indicate? It indicates a peripheral small ischemic event. You don't do anything. Let's go back. What would have happened here? You know, this whole damn thing would actually be a big fat in fact, isn't it? You can see that. And that's got, you know, the post thrombolysis. You could see that it's got minimized. Myxoma is something which is a great mimicker. I mean, atrial myxoma can come in various forms and sizes and what. It's I think, we've had a lot of great mimics in the history of medicine and mankind. At one point of time, syphilis, then came tuberculosis, then we have even, I think even cysticercosis, and myxoma has been there anyhow. So, thrombolysis is reasonable, but then definitive management must be done. Dissections as it stands, you probably don't need to thrombolyze. They heal very, very well. Although thrombolysis, double antiplatelets, single antiplatelets, all have been, even stenting has been done, has been recommended. But as it stands, I don't think you need to thrombolyze. They do pretty much well. But it also depends upon where the dissection is. So, when you have this common garden variety of arterial dissections, you're really not looking at a dissection before remember your vessel imaging is being done after you start your IVT. And a lot of times now we are giving bolus of tentative place and then we're doing imaging. So, the common garden extracranial dissection, you're safe. Go ahead and thrombolyze. The aortic arch dissection, don't. Intracranial dissections, we don't know. There's uncertainty. Therefore, it's probably, if you know it, maybe don't thrombolyze. But again, I'm coming back to the same situation. You don't even know whether there is a dissection because you're just taking a plain CT and then you're going ahead. In intravenous thrombolysis with alteplase, they're at least on an infusion, tenecteplase, you give a bolus. You've already done and ended there. So, a lot of times we learn later. So, common garden dissections, you can go ahead. Others, if you know, be careful. Aortic, don't. Aneurysms, AVMs, these are the guidelines. I'll read them out. So, incidental, unruptured, unsecured intracranial aneurysms less than 10 millimeters, it's reasonable, probably recommended. But when you have large, giant, unruptured, unsecured, data is not well established. When you have this giant aneurysms which are thrombosed, unlikely to rupture, but they can cause a lot of issues. Recently, we had this vertebro-based, the dolichoectasia. There was a big fat aneurysm which has developed, got thrombosed, and now he actually had an ischemic event and then went and ruptured and had a subarachnoid bleed. Quickly, within 24 hours, and then when we went into literature, we found literature documenting these, and these were actually documented post, in autopsy series. In intracranial AVMs, consider if likelihood of severe stroke-related disability and mortality is is much more than the risk of ICH. So all of these cases you have to weigh the risk and benefit ratio, individualize your patient. So left-sided thrombus for patients with major ischemic stroke likely to produce severe disability, but a known left atrial or ventricular thrombolysis may be reasonable, but be very, very, very judicious here, because it is known that when you thrombolyze, the thrombus gets into small pieces, and those go up, embolize and cause problems. They can go into arteries, you don't want them to go. And for patients presenting with moderate acute ischemic stroke likely to produce mild disability, known left atrial or ventricular thrombus, treatment with IV alteplase is of uncertain net benefit. Okay, so when you know that there is a left atrial or ventricular thrombus, red flags, be very, very careful. Mimics, postictal hypoglycemia are the most common stroke mimics. Now the guideline is, if it is taking you much longer time to prove it's a mimic, then go ahead and thrombolyze. Don't actively go and thrombolyze a known hypoglycemia with a sugar of 30. But there are situations, and these are practical situations even we had faced. They would, the strips are not okay, they are old. So when you're looking at a strip and you get a 140 blood sugar, when you're looking at a fresh strip and that becomes 30. So those kind of situations. And most importantly, postictal, they wake up at ungodly hours. They come at 2 in the morning, your MR is not working, there's no way it is a postictal deficit or it is a fresh stroke. So when it is taking time to prove it is a mimic, then go ahead and thrombolyze, but don't actively thrombolyze a stroke mimic. So that's where we are, boys and girls. I know now you're very, very tired. So if there are any questions, shoot. Let me see if I can answer. I really don't know how this is. This person has disappeared from here. Any questions? You can type in. I wonder how this works. Doesn't matter. Catch me in the ward and ask me questions. Okay? Alright. I am signing off. Bye bye. Bye, boys and girls.